The topic given to me is the pulse of uveitis. I don't call it pulse, but I want to tell the nuggets of uveitis which I have learned, and I will be sharing some cases only. Case 1, 30-year-old female, immunocompetent, and you can see that necrotizing retinitis with hemorrhages in the posterior pole. Now I ask all the audience that anybody can tell the diagnosis of this case. Necrotizing retinitis with hemorrhage, posterior pole, immunocompetent. Okay. It's not difficult. If you look at the patient as a whole, you can get the clue. And what is the clue here? The patient's forehead had got vesicles, herpes zoster vesicles, and the patient had actually varicella zoster virus retinitis. And the patient responded with a course of intravenous acyclovir for 7 days. You can see that the right eye lesions is markedly regressed and left eye is almost gone. So look at the patient as a whole in addition to a slit lamp and indirect ophthalmoscope in a room light on is quite important in uveitis. Case 2, this was a case referred from Mumbai, 43-year-old male, dimness of vision and floaters, diagnosed as CMV retinitis, HIV positive, treated with intravenous ganciclovir, thinking that is a CMV retinitis. I used to shake hands with all patients routinely before the COVID era, of course, but I found something wrong in his hands. What I found? What is that? There was the rashes, syphilitic rashes was there, and my diagnosis was not difficult. I could find out that there is a exudative retinal detachment and subretinal precipitates over there, and that is suggestive of syphilitic retinitis. RPR and TPHA came positive, supporting my diagnosis, and treated with the intramuscular penicillin, and after treatment, complete resolution of the inflammation. Syphilis is often a one-time disease, and you can, if you can make a diagnosis, you can make a really a vision-saving diagnosis, and this can really bring back joy to the patient and to you also. It was an accidental finding, shaking the hands so you get the clue, but you should have a prepared mind what you are doing and what you are finding. Case 3 is also interesting. 47-year-old man, pain, redness and swelling for 2 months, diagnosed as tumor with intraocular extension, advised radiation and brachytherapy, referred to our institute for the same. And if you look at that one, you might think that it's a nodular scleritis, another nodular scleritis or scleral tumor, but there is no indentation artifact, only indentation, no intraocular mass lesion, homogeneous mass arising from the episclera and sclera. So the clinically nodular scleral inflammation, we did all workup for autoimmune related inflammation. But what else you want to add now at this stage? You have finished autoimmune related inflammation, you have finished most of the other things, tumors, UVM doesn't show anything. What it could be? RA factor ANA negative, Cianca Pianca negative, VDRL was positive and RPR was positive and TPH was positive. What it turned to a nodular scleritis actually is a nodular syphilitic scleritis, and with benzathine penicillin is shows complete control of inflammation. So this was published, this was a rare situation, masquerading as an ocular tumor, but sometimes you need to think out of the box also and to make a diagnosis. So everything, it doesn't fit anything, everything comes negative, you need to think about syphilis, which can mimic any type of the eye disease. Case 4 is also interesting. 30-year-old male came from USA, and they labeled it as a serpiginous choroiditis. Metamorphosis in both eyes, and you might be thinking that, okay, it has come from a bigger institute, and there's a serpiginous choroiditis. You look at the patient carefully, it doesn't have the really a geographic border, and this pinkish in color. So I suspected something wrong. I did an ultrasound, simple ultrasound, and ultrasound clinched the diagnosis. What is it? What is the diagnosis? choroidal osteoma, and CT scan clinched the diagnosis, choroidal osteoma. So it was a choroidal osteoma. Always keep an open mind. Don't be carried away by some diagnosis made by somebody else, even if it is a higher institute. Case 5 is a painless gradual dimness of vision, 9 months, 57-year-old lady. She was diagnosed as an Apex Institute as a TB choroiditis with ATT given 6 months. But if you look carefully, there was a leopard skin-like lesions in between the yellow lesion. And it is a very subtle sign, but if you look carefully, it indicates that there is not really a choroiditis. So I suspected lymphoma. I told my clinician to go ahead for doing a fine needle aspiration biopsy, and I was correct. The fine needle aspiration biopsy showed necrotic background. Lymphoma cells always have necrotic background. They are friable cells, and in between that, there is a large lymphoma cells were seen. And 6 months after, the patient developed CNS lymphoma. So be mindful of even a subtle sign, and that can give a clue. Case 6 is a 35-year-old man, dimness of vision for 1 month, diagnosed as choroiditis, treated with high dose of oral prednisolone. But if you look carefully, this may not really look like classic choroiditis. But anyway, you should do a fluorescent angiogram, isn't it? And we did a fluorescent angiogram, and what I found, there is a multiple leak CSR. So it's a diametrically opposite diagnosis, and the treatment is completely different, and steroid is contraindicated in CSR, multiple leak CSR. So lesson learned, always do an FFA in all cases of active choroiditis. Last case. This is the last case, 15-year-old girl, sudden blooding of vision in the right eye. Vision was counting finger at 50 centimeters. Diffuse KPs studied over the cornea. Some of them were quite large. I thought of span uveitis due to the TB or sarcoid. So this is the picture. I couldn't see the fundus. But I was all the time suspecting that there may be something wrong because the vision was not correlating. And at the earliest opportunity when I looked at the fundus, I did the AC tab for PCR for MTB thinking the TB, and it came for a positive for MPB64 gene for TB. I put the patient on anti-TB treatment with the topical and systemic steroid. And what happened, when the media cleared, I found there is not TB. It's a toxo lesion sitting over there. So diffuse KPs can be due to the toxo, and I learned that lesson. So it was toxoplasmic retinochoroiditis. I didn't do the ELISA for the toxoplasma thinking that it's a TB or sarcoid. That was a mistake. I was misguided by the PCR. So the lesson learned after 33 years of the uveitis practice, I am learning, and that's true. Thank you.